Mechanical thrombectomy became a huge part of what we do these days, and I get asked all the time what technique you use. We have so many different options, but I think over time we have now standardized the way how we do this procedure. And I'd like to share with you some of the reasons why we do that. First of all is you've got to have flow reversal and control the flow. Second part involves of the ability to control the clot or trap the clot. And then the third is the execution to be able to one time do a pass and remove the clot with a cleanest type of revascularization, a TK3. The more often you can do that is what would perhaps be the best, the ideal type of mechanical thrombectomy technique. For me, over the years, it came down to have a balloon guide, approximately an intermediate catheter at the face of the clot, and a stent retriever deployed and interacting with the clot. When all these forces are interacting together, you have aspiration, locally aspiration, proximally with flow reversal, and you have then the stent retriever actually protecting the clot from desembolization and also grabbing the clot with the aspiration together. When all the system works together, you have, we have seen this not only in my own experience but also in the literature, that you have higher rate of revascularization with TK3 as well as you have also the first pass effect, which is the ability to get it right the first time, which is really important. We're going to go over the trap technique in this video that we had a 52-year-old woman that came to us with an acute stroke involving the left middle artery. She was within the Dawn protocol, so she had a mismatch between on CT perfusion, and her initial NIH was 21, and you will see details of how we did the trap technique in the first pass success for recanalization. But the most remarkable in the end always is that she had an extreme good recovery, and in a relatively short period of time, within 7 to 10 days, she was at NIH of 5. In this case, we start demonstrating the harmony you have to have with your team, and this is, in this case, try to open all the devices in advance. But you can see here that we have the FlowGate 2 set up, and the balloon is prepped, usually with a half and half contrast, about 5 cc's, and after prepping the balloon, we use that over, in this case, it was using a VTK inner catheter, but in many cases we can use, you can see the tortuosity in this particular case, that's why we chose a VTK, but we can also use the inner catheter that comes on the insert, for sure for right common and left vertebral. The left common carotid artery, in general, the VTK seems to work better. But you can see after getting the relatively fast access to the left common carotid artery, we park the FlowGate 2 in the common carotid artery, and we're going to obtain an initial imaging of the anatomy prior to advancing in the internal carotid artery. The setup from here on will determine, in this case was a, as you can see, pretty significant compromise of circulation, but there is flow on the through the bifurcation, so it seems to be mainly an intracranial problem, but you can assess how the anatomy of the cavernous carotid artery is, and that is what helps us between what type of intermediate catheter to use. In relatively younger patients with an anatomy that is favorable for navigation, we tend to go with the Cat 7. The reason to choose a Cat 6 today for me would be if you have extremely tortuous anatomy, as well as the size of the vessels and the any type of complexity also at the arch level. I think all those things may make me more inclined to use the Cat 6 over the Cat 7. Now you can see here we loaded the microcatheter with our Synchro Support wire. This is the Trevo microcatheter, and we use almost uniformly now 430 Trevo. It seems to have really good trackability in a consistent way, as well as allowing us the flexibility to do more proximal and distal treatments. Here you can see that we have an idea of the anatomy and where the occlusion is. So on AP and lateral, using the Synchro Support wire, which has been really helpful to be able to get into the place we want with the support we need without losing that navigability that we're used to have with the Synchro wire. You can see also that I have a torquer on the wire, as well as a gentle J shape at the tip, and trying to find the best view here, as the patient is in this case not under general anesthesia, so the patient is awake and has some movements you can see. So you want to be very gentle on the access with the wire to the distal anatomy, and once you have a position, it seems that always checking. You see here on the B plane, you have the position of your balloon guide in view, so you can see that it's been advanced into the internal carotid artery over the Trevo microcatheter and the Synchro Support wire without any difficulties. So I have the view of the distal portion, always trying to go on the at least passing M2 to M3 level beyond the clot, and once the microcatheter is in position, we remove our Synchro Support wire, and now we're about, and you note that my tech here had everything ready to go as you're calling this out prior to needing the device, and the team is prepared to hand it to you as soon as your next step is ready to go. So Trevo is going up despite of a significant tortuosity. You see the position of a balloon guide at about C2 level, and now you're going with the Trevo without having significant you see movement of the patient's head. Seems to be relatively well tolerated, despite of a significant navigation or a challenge with this tortuous anatomy. So now we are unsheathing the microcatheter and deploying the Trevo. So this is a very important point in terms of the interaction of the Trevo with the clot. As you can see here, the microcatheter is gently removed, and we have our balloon guide in position. And this is a very important step because it allows us to have a full integration of the clot with the stent retriever, and the 430 seems to be a very good device to the majority of situations that we encounter. You can see that the visualization of the device is very good, and that also allows us to see if the device is fully open, which is really important, the interaction with the wall, and to figure out if you have, if you need to put any kind of a forward force on the Trevo so that it can expand, or if it's very well relaxed and well opposed against the vessel wall. So always pay attention to the deployment of the Trevo and how it looks in the vessel to make sure it's well integrated with the clot and the vessel wall. The aspiration catheter in this case is a Cat 7, and we are in position navigating to the to trap now the clot between the stent retriever and the you can see here as the aspiration catheter is going up into the more challenging anatomy, which is the cavernous, we start to connect to the aspiration, and the aspiration then starts just proximal to the clot, and then as soon as you stop seeing the aspirations when you engage the clot. So we have now a combination of distally you have the stent retriever, and then proximally you engage the clot with the aspiration starting just before you arrive to the clot. You can see here as the aspiration is continuing, we have for a period of time prior to pulling the whole system down, we will inflate the balloon, as you can see here on the balloon guide. So it's a very important step now is that you have the local aspiration, you have the stent retriever connected to the clot, and you have the balloon guide now with flow reverse. So as you ask your team member to use, in this case we use a 60 cc syringe, and that's going to start the aspiration and flow reversal at the level of the balloon guide. Meanwhile, this is the time that you're letting the clot integrate with the stent retriever, and the intermediate catheter, or Cat 7, is aspirating the clot proximally at the level of the proximal portion of the clot. And then now you see the two hands, how you gently pull the system together. And here I think you feel you have total control of the situation, because you have your balloon guide in position, not allowing any distal embolization, and you have the clot trapped between the Cat 7 and the Trevo stent retriever. Now you can see a very important step here is that we open the rotating hemostatic valve so that the Trevo can pass through it without flaking off any clots. The balloon guide is still up, and you can see that I tend to disconnect and allow for back bleeding. You can see that we have clot is kind of in the middle of the stent retriever, showing that that's why the length is always important, having a 30, because the clot didn't roll out of the stent retriever. And you can see how well integrated it is, hard to remove it, and very much trapped in there. And many times, depending on the type of clot you have also more of a component on the Cat 7, but in this case was very much connected to the stent retriever. So now we let back bleeding from the balloon guide, and I'm going to then gently just allow the flow to the balloon guide to come down. So the balloon is deflated, and you see how fast that was done without having to, since it's a half and half contrast and saline, you're able to relatively, with one aspiration, deflate the balloon. And now we're ready. You see that I do one more aspiration to make sure that no clots are in the balloon guide. And then we're going to position ourselves now for the run to confirm the results of the mechanical thrombectomy. So we went from a complete occlusion of the carotid artery into a, in this case, I always try to do a little bit of an oblique view to see the bifurcation well of the middle cerebral artery, as well as the distal anatomy. And then we have recanalization, looks like a Tiki 3. I hope these highlights help to better understand the different components of this technique, and this case illustrates very well how, after standardizing and coordinating your team, you can have this done in a very efficient way and achieve more often a first pass total Tiki 3 recanalization.